Well, good day to everyone joining us and welcome to today's X-Talks webinar. Today's talk is entitled Rapid Diagnostic Testing of Positive Blood Cultures and Impact on Antimicrobial Stewardship. My name is Andrew Jordan and I'll be your X-Talks host for today. And today's webinar will run for approximately 60 minutes with time for a question and answer session with our speaker. This webinar is designed to be interactive, and webinars work best when you are involved. So please feel free to submit your questions and your comments for our speaker throughout the presentation using the questions chat box, and we'll try to attend to your questions during the Q&A session. This chat box is located in the control panel that's on the right-hand side of your screen, and if you require any assistance, you can contact me at any time by sending a message using that chat panel. And at this time, all participants are in a listen-only mode, and live audience members today can apply to receive a professional acknowledgement for continuing education, or PACE credit, issued by the American Society for Clinical Laboratory Science through our exit survey at the end of today's session. Certificates for approved applications will be emailed by July 13th. And please note that this event will be recorded and made available to you for future download. And now a big thanks to Luminex, who helped develop the content for this presentation. At Luminex, their mission is to empower labs to obtain reliable, timely, and actionable answers, ultimately advancing health. They offer a wide range of solutions applicable in diverse markets, including clinical diagnostics, pharmaceutical drug discovery, biomedical research, genomic and proteomic research, and food safety. They accelerate reliable answers while simplifying complexity and deliver certainty with seamless experience. All right, now I'd like to introduce our speaker for today's event. Dr. Brad Crane is a clinical pharmacy specialist in infectious diseases at Blount Memorial Hospital in Maryville, Tennessee. He graduated with his doctorate in pharmacy from the University of South Carolina and completed postgraduate training with a pharmacy practice residency and a critical care specialty residency at the University of Tennessee Medical Center in Knoxville. And Dr. Crane was a critical care pharmacist for 10 years before he justified and transitioned into his current role as the Infectious Diseases pharmacist and director of the Antimicrobial Stewardship Program. He's a board-certified pharmacotherapy specialist with added qualifications in infectious diseases. Dr. Crane is a current member of the Society of Infectious Diseases Pharmacists, Making a Difference in Infectious Diseases Pharmacotherapy, American College of Clinical Pharmacists, and the American Society for Health System Pharmacists. He is a clinical assistant professor for the University of Tennessee College of Pharmacy and has presented at several professional meetings on antimicrobial stewardship and rapid diagnostic testing topics. Excellent. Well, it's now with my pleasure to hand the microphone and the presentation over to Dr. Brad Crane right now.
Thank you, Andrew, and good day, everybody. I'm very excited to be talking with you guys today about two things that I'm very passionate about, antibiotic stewardship and rapid diagnostic testing, and the advancements that we're doing and how they can work together synergistically. For those of you who are on Twitter, feel free to look me up at ASP_PharmD. I do like to tweet quite a lot of things about antibiotic stewardship as well. For full disclosure, I am receiving an honorarium to speak today from Luminex, but however, the content of the presentation was very minimally affected by them. They just basically approved my slides, but were kind enough to allow me basically to speak to you today on things that really I want to speak to you about. And there is one point in the presentation I'll be talking about an off-label use of a medication. I'll make sure to point that out when we get to that point. So for the next 45 minutes or so, I'm going to be reviewing the correlation between RDT, or rapid diagnostic testing, with antibiotic stewardship programs. We're going to be discussing and listing the potential clinical and financial outcomes associated with RDT, looking at various metrics. We're going to review the microbiology and pharmacy responsibilities when it comes to both of these aspects, and determine the feasibility of implementing this technology in a non-teaching community hospital such as the one I'm in. So I'm going to turn it over to Andrew, who's going to be helping with some poll questions.
That's right. So we have 2 back-to-back polling questions for today to get us started. And you can vote on these poll questions by clicking on your screen right now. The first question we have for you, which best describes your profession or department? Microbiologist in the microbiology department, maybe you're in the laboratory but not micro. Another option there as a pharmacist or other. Which best describes your profession or department? Looks like most of you have voted here. That's great. I'll be closing polling right now. And let's take a look at the results. Not surprisingly, 57% of you microbiologists. Thanks everyone for voting for that. And let's move on now to the next polling question. That is, which best describes your primary institution? The options this time, large, so maybe more than 500 beds and or an academic hospital. Your second option there, non-teaching community hospital, 200 to 500 beds. Your third option, non-teaching community hospital where it's less than 200 beds, or other. So which best describes your primary institution? Looks like most of you have also voted on this polling question. So I'll be closing polling here in a moment. Still lots of votes coming in, boy. All right, well, I'll close this polling question right now, and let's take a look at these results. Interesting, more split across the board. 31% of you saying other, 25% saying a non-teaching community hospital, less than 200 beds, 24% in a large academic hospital, and 20% saying non-teaching community hospital. Interesting. Thanks everyone for voting on those 2 polling questions. We have one more a little later in the presentation, but for now, I'd like to hand it back to Dr. Brad Crane.
Thanks, Andrew. Great to kind of have an idea of who I'm speaking with today. Interesting, about 57% were micro, so it looks like we have quite a variety, and quite a variety on the type of hospitals that we're going to be seeing. So I'm going to explain to you where I am and how it works where I am, and see how that may or may not relate to your setting, but hopefully you can take a lot of the concepts away and still apply it to your institution. Blount Memorial is licensed for 304 beds. We are a non-teaching community hospital. Our average census is somewhere around 220, depending on the season. We do have a formal antibiotic stewardship program that we got approved with our administration back in October of 2011, and is primarily driven by the pharmacy department, with me being the head of it. For our micro department is open 7 days a week, and probably not too uniquely, we're not open 24/7 in the micro department, just 6 o'clock till 2 o'clock, which they just closed here on the East Coast. For blood cultures, our percentages are quite high, about 75 to 80% are gram positives, and about seeing 900 isolates a year. But that works out to be about 2 new gram positive cultures per day, and that's just blood cultures. When you look at our antibiotic stewardship team, when you look at the guidelines, we kind of correlate with it. When we initially built the team, the core members were primarily myself and the ID physician, in which we do compensate them for their time. And then as needed clinical micro, our infection control or infection preventionist, information technology, and administration. However, currently, we've kind of swapped roles a little bit to where I'm on the phone with microbiology at least a couple of times every single day. And I may or may not speak with my ID physician as we don't have any kind of formal rounding. But the role of the clinical microbiologists and the microbiology department has absolutely been a key role when I work with them on a day-to-day basis when it comes to my antibiotic stewardship. So for those of you that may not quite be familiar or have just an idea what antibiotic stewardship is, basically the primary goal of antibiotic stewardship is when you're dealing with managing antibiotics is to optimize the clinical outcomes associated with antibiotic use. And at the same time, you want to minimize the unintended consequences by using antibiotics. So what kind of unintended consequences? Well, one that most people probably think of first are the toxicities associated with them. Could be something like nephrotoxicity with like vancomycin or aminoglycosides. There's also the selection of pathogenic organisms. So these antibiotics may kill off the good microbiota that's in your gut, and that only leaves the ones left behind that are actually resistant. And then one big one is going to be, of course, C. diff. And then there's the emergence of resistance. This has actually become such an issue that it's now been deemed a national security threat by the national government. Back in 2014, President Obama actually issued an executive order calling combating antibiotic-resistant bacteria, or CARB. And we'll talk a little bit more about that here in just a moment. So when we look at what are some examples of antibiotic stewardship, I have a lot of them listed here. For me, one of the biggest things for it to be impactful has to be in real time. If we're going to make an impact, I need to have the same information as the providers. It's only one thing to go retrospectively to say, you know, Dr. So-and-so, you should have done X, Y, Z. Well, I'm using the same information that they are. The indication for antibiotics, a lot of times fluid may actually mimic infection. It could be fluid in the lungs, looks like a pneumonia. It could be fluid in the legs, looks like cellulitis. So do they need any antibiotics? And what are some things we can help determine to see if it's actually an infectious process or not? Antibiotic selection is one of the biggest things I do. Escalation of antibiotics. That includes making things more generalized, maybe a bigger gun, using a bomb, because we're not exactly sure what it is and they have risk factors for resistant organisms. Or what I usually like to focus more on is de-escalation, because we start big, but we need to really narrow the spectrum or get them on antibiotics that are really pinpointing the organisms that we help identify. The antibiotic dose is a big thing that we do. It's got to be dosed high enough so it actually works, but not so high that you get those toxicities that we're trying to avoid. Antibiotic duration is also a real hot topic. Some patients may need to have longer durations than others, like endocarditis. Some it could be a very short duration, and we're finding more and more evidence that shows shorter duration is often just as effective. And one of the final things is education across the spectrum. Education is really key, because I can't look at every single patient, but if I can provide the concept behind it, then those that are doing the antibiotics on a day-to-day basis can take that concept and apply it to future patients without me having to necessarily get involved. So what is the connection between antibiotic stewardship and rapid diagnostic technology? Well, again, coming back to that CARB report, this was a report that was given to President Obama back in September of 14, and is by the PCAST, or the President's Council of Advisors on Science and Technology, basically informing the President that we have an antibiotic resistant issue going on in our country. And within this report, this was the table of contents. And just to kind of point out in one section right here, one section to combat antibiotic resistance is to have good stewardship of our current antibiotics. And it says right there, we need to advance antibiotic stewardship, but right underneath it, it says rapid point of care diagnostics. So antibiotic stewardship and rapid diagnostic technology right there is next to each other in this national report. Now, in response to this report, how we're going to do this? Well, they came up with the National Action Plan about 6 months later. And within this National Action Plan for the CARB, goal number 3 listed in there is to advance the development and use of rapid and innovative diagnostic tests for the identification and characterization of resistant bacteria. And I want to focus on and use. It's one thing for all these companies to be able to create this technology, but it needs to be able to be used by those on the front line. And why do we want to do this? We want to help healthcare providers to make optimal treatment decisions and help decrease the unnecessary or inappropriate use of antibiotics. So with that, we're going to have our next polling question.
That's right, and that's the final polling question of the day. Again, you can vote on this in real time by clicking on any of the options there. This final polling question: does your institution perform rapid diagnostic testing on blood cultures? Your options: yes, for a while now. Yes, but you just recently started. Maybe not yet, but you're in the process of it though. Or your last option: nope, and probably not in the near future. So does your institution perform rapid diagnostic testing on blood cultures? Looks like most of you have voted here on this polling question, so I'll close polling here in a moment. And let's take a look at this final poll result. All right, 35% of you saying yes for a while now, 33% saying not yet, but you're in the process of it, 22% saying nope, and probably not in the near future, and 10% saying yes, and you just recently started. Interesting. Thanks everyone for voting on that, and I'll hand it back to you.
Great, thanks, Andrew. And that's very interesting to hear the breakdown that a lot of people listening to this webinar are either not doing it yet or just beginning the process. So hopefully you'll be able to use this information and take it back with your institution and hopefully make some advancements, because I really feel that it's a great idea. When you look at antibiotic stewardship, there's actually guidelines published back in 2007, and it actually broke it down into core activities and supplements to the core activities. And I won't go through all those today, but I will go ahead and point out when you integrate rapid diagnostic technology, everything highlighted here in red are examples that I feel that this technology can actually have an impact when it comes to antibiotic stewardship. And if I had to pick out a single one that probably impacts it the most, is the one for streamlining or de-escalation of therapy. Again, we're very good at starting broad spectrum antibiotics, such as Vancomycin and Cipro, for those that are familiar with the antibiotics. However, we're not necessarily as good as stopping the ones that we don't need, and rapid diagnostic technology can help with that. So how is this technology making that impact? For those that are not very familiar, the common response by providers, as soon as someone has a positive low culture, and let's go ahead and say it's a gram-positive cocci, because that tends to be the most common, the knee-jerk reaction is to put them on empiric vancomycin. Ideally, you want to make sure that they're symptomatic and there's a good reason for it, because we do have low culture contamination that's out there. But a lot of physicians have a knee-jerk reaction. They just put them on vanc because it's going to cover pretty much every gram-positive that's out there. And then they wait to see what does it turn out to be. Well, this technology actually decreases the time of knowledge to that key information. So what kind of key information are we looking for? Well, we have to review the conventional microbiological process, which many of you are probably familiar with. You got to incubate the sample, and eventually you'll get some growth, and you're going to do a gram stain. Isolate some colonies, set it up for an ID and susceptibility testing. And most of you in the audience probably know that this takes on average anywhere for 2 to 4 days to have this process to get the information that we need. When you integrate rapid diagnostic technology, it doesn't make anything grow faster. However, when you do get growth, you do that gram stain, this is when we can go ahead and get that rapid diagnostic technology. And in only 2.5 hours using the Veregene system, this is when you can get your results, and we're going to take some action. So what kind of results are we seeing? Well, again, with the Veregene system, which is the system that we use here at our hospital, it'll tell us potentially what the genus is. It's a staph genus species. It's a strep species. I've had 1 listeria since I've started this program. But it'll also go down to the species level as well. It'll tell me if it's Staph aureus, which is one of my most concerning ones, Staph epidermidis, which is our most common coagulase negative staph, and Staph lugdunensis, which is also another coagulase negative staph, but it's very unique in which it mimics Staph aureus, and we usually want to treat it. So that's one thing that's very unique with the Veregene system, how it does detect that lugdunensis species. And also with strep, it'll tell me if it's strep pneumoniae, part of the anginosus group, group A and group B strep. And also tell me if it's an Enterococcus faecalis or faecium. It also incorporates resistant determinants. So with MECA, it'll tell me methicillin resistance for my Staph aureus, my Staph epi. And it'll also tell me vancomycin resistance using the Van A and Van B for the Enterococcus faecalis and faecium. But all in all, you look at all these combinations, and there's actually 16, including our multi-drug resistant MRSA and VRE. This is what the report comes out from the machine. And you can see the items that are detected. So in this case, the Staph is detected, but it also goes down to the species and says that the Staph aureus was also detected. It then goes on to the MECA and shows that the MECA was also detected. Now, not only is it important to know what is there, but sometimes what isn't there. For example, Enterococcus in this case was not detected. And sometimes knowing what they don't have when you might be suspicious of it is just as informative as for those that it does detect. But at the very top, it does summarize very clearly, so you don't have to worry about accidentally missing something with all the words on the bottom section of it. So again, the key information, what am I going to do with it? Well, just by knowing what the organism is that's produced by the Veregene system, I know if likely that it's a pathogen, therefore I know I'm going to have to treat it, or is it likely a contaminant, and therefore I probably do not need to treat. For example, if it's a Staph aureus, Staph lugdunensis, most of those strep species I just shared with you, or the Enterococcus, faecium, and faecalis, I know most of the time I'm probably going to have to go ahead and plan on treating those because those are likely true pathogens in that blood culture. However, for Staph epidermidis, if it's just staphylococcal species, so it's just a coagulase negative staph, or if nothing is detected, most of the time that turns out to be a micrococcus, then unless they have risk factors or it's 2 out of 2 or something along those lines, then in general, I know I don't need to treat it. I'm still going to assess them just to make sure they don't have like hardware in place, any kind of lines, or they're truly symptomatic. But most of the time, it's likely just a contaminated blood culture, and I don't need to focus on it. In addition to knowing whether or not I need to treat it, I can actually determine what I need to treat them with. For example, that empiric treatment of just putting them on something can go to targeted treatment, which means a much more focused antibiotic. For example, I know using my local antibiogram here at our hospital that if it grows out to be strep pneumoniae, then that empiric vancomycin that they may have put them on, I can go ahead and de-escalate down to just ceftriaxone, because we very rarely will see ceftriaxone resistance or strep pneumoniae here. And for group A strep or strep pyogenes, I know that empiric vanco that they started, that organism is basically universally susceptible to penicillin. So I'm just going to put them on a penicillin with or without clindamycin for the eagle effect for the toxin production. And when you add in the resistance determinants, again, that MEC-A for the methicillin resistance and the VAN-A, VAN-B for the enterococcus for the vancomycin resistance, it gives me even more information. For example, if it's a Staph aureus, but it does not detect the MEC-A, then I know that's methicillin susceptible Staph aureus. In that empiric vancomycin, I can de-escalate down to cefazolin or nafcillin. If it's enterococcus faecalis, which tends to not have vancomycin resistance, then I know I can de-escalate that vancomycin down to ampicillin and put them on a synergistic drug with either ceftriaxone or gentamicin. Or if it's enterococcus faecium and it does show a VAN-A or VAN-B, then this is actually vancomycin resistant enterococcus, in which that empiric vancomycin won't even work because it's vancomycin resistant, and I would have to escalate them up to daptomycin or possibly linezolid. But these are all examples where you can see the empiric vancomycin, that is that knee-jerk reaction, we are able to de-escalate or potentially escalate them to a much more optimal antibiotic that's likely to give them better outcomes. So what are some of those outcomes? Well, there's been studies that show when you use this technology with positive blood culture, there's both clinical and financial benefits to it. Some of the clinical outcomes, we see the decreased time to the optimal antimicrobial regimen, which with me as a stewardship pharmacist, that's one of my key focus. It also will decrease the length of stay, not only in the ICU, but overall hospital length of stay as well. And then you do increase the likelihood of improving mortality. On the financial side, you do see a decrease in antibiotic use most of the time, and you will see a decrease in overall hospital costs as well, usually because you have a decreased hospital length of stay. Most of the studies at the time when we were looking at this, most of the data at the time was only performed in large academic medical centers. And as many of you stated earlier, we're not in that kind of situation. We're actually in maybe a community non-teaching hospital. So the question that we ask ourselves is, well, how does this work at our hospital? Can we apply that same information to us? Well, these are the steps that I went through to get our technology approved at our hospital several years ago. The first thing is that I would recommend is getting an RDT champion. It can be a pharmacist such as myself. It can be maybe a physician. It could be someone in the lab, someone who's willing to take it through all the various committees and make sure it doesn't get dropped and make sure to kind of keep it pushing through all the different steps. And along with that, other things is identifying key players that you need and within all the various departments. You need, if it's in my case a pharmacist, I need to make sure my lab is on board, of course, that they're going to support this. And I need to get my key physician players. For example, if you have an ID physician at your hospital, make sure that they're on board with the concept. If you have an ICU intensivist, pulmonology group, maybe the same group, you want to make sure that they will buy in as well. If you have a hospitalist situation where most of your patients are seen by a hospitalist, make sure some of your hospitalist leadership is also on board. If you get them on board with the concept ahead of time, it'll make implementing it that much more easily. And then there's some research. What I'd like to say round one. One is you got to know what kind of outcomes you'd expect to see so you can start preparing to see what kind of outcomes you're going to start measuring. And there are multiple products out there, and hopefully you've already seen some of the benefits that we're going to be seeing, and I'll be showing you some more with the Verisgene system. And then there's round one of presentations, and it's round one of multiple presentations. You can see there that I gave one presentation for a CMO, or the Chief Medical Officer, and that had a little bit more of a clinical focus when I was describing the presentation, how this will impact patient care. And then I had a separate presentation that was a little bit more financially focused for our CFO, or the Chief Financial Officer. I then presented it to the CEO, who basically said, well, what do my other two guys say? And if they're on board, he was on board. And knowing that, especially financially, they may be wondering, is this going to be financially appropriate and things like that, despite all the evidence that may say it does. If they're not willing to just kind of say, go ahead and do it, you may have to just suggest a trial period, or a pilot is what we'd like to call it. For us, that's what we ended up doing. And with a pilot, or even if you go full blown, there is going to be a lot of preparation involved on the front end. For example, what's going to be the workflow process at your facility, and what are responsibilities within the different departments. Within micro, you're going to have to come up with a policy and procedure. You have to learn how to use the equipment, do some quality control. In addition to that, micro is going to have to actually perform the rapid diagnostic test. And in our hospital, we went from 6 a.m. when they opened to about 11 o'clock. And we had to stop at 11 o'clock because it takes about 2.5 hours to run the test. And by the time you get the test results, they got to be able to call it to someone through the computer system, and they need to be out the door by 2 o'clock. So therefore, our cutoff time was 11 o'clock at that time. Anything that came back positive after 11 o'clock, they would keep the sample and just freeze it for us. And the other thing I want to point out is that's kind of unique for a lot of community hospitals. Most community hospitals may not have microbiology open past 2 o'clock or very limited hours. So that's one thing that really makes us different compared to a lot of large academic medical centers. In addition to microbiology, they need to call the results. And I'm going to emphasize how important it is to just calling and not just putting it in the computer system unless you have some kind of technology that will alert people otherwise. The reason I say that is if you just put it in the computer system and no one sees it, then you start losing the benefit of the rapid aspect of the rapid diagnostic technology. Most of the time, people are going to call either a pharmacist or a physician. In our hospital, we decided that it would be all called to me because I was the champion of this. I wanted to know what was going on. And when I'm not there, all of our clinical pharmacists are basically evaluating it. And one of the reasons why we decided to have pharmacy do it is that there's a limited number of us. It's a lot easier to educate us altogether compared to the hundreds of physicians that we have on staff here that may or may not even come to the hospital very often. But as long as you call it to someone that's willing to, or if someone in pharmacy isn't, you can always give it to a physician that might be interested in it. Perhaps if you have ID at your hospital, it could be one of the ID physicians. So going back to pharmacy, one of the most common questions is, well, I'm a clinical pharmacist, but I don't have the training that Brad does, or an ID pharmacist. What do I really do? And so we'll get to that in just a moment for the pharmacy section. So with pharmacy to prepare, we have to do education of what exactly this technology is, certain algorithms of what does this mean, what are we going to do with it, create some data collection forms if you're going to do data collection to help justify the technology. And when it comes to pharmacy responsibilities, one of the biggest things is we need to interpret the test results. What does MEC-A mean? What does this VAN-A mean? If nothing is detected, does that mean there's no organism? No, that's probably not the case. So pharmacy, we're going to interpret the results, and we're going to then determine, is the patient being treated optimally? Are they on the best antibiotic possible? One of the first things is, do we need to treat them or not? The best antibiotic could be no antibiotic because it's likely a contaminated blood culture. The other thing is, if we do have to put them on an antibiotic, what is the best antibiotic? Do we need to begin antibiotics because they're not on anything? We think, nope, this is a true bacteremia. Do we need to modify the regimen, kind of what we were discussing before? Maybe vancomycin isn't always the best answer, or it's probably contaminated blood culture. We don't have to have any of the antibiotics. And then there's the additional tests. May recommend, hey, this repeat blood cultures because we're not exactly sure if this is a positive blood culture or not, or maybe a procalcitonin. Or a lot of times I'm recommending additional procedures be performed, such as an echo if I'm concerned about endocarditis, or a CT MRI, depending on where I think the source of the bacteremia is. And one of the other things is to determine, do we need to have an ID specialist on the case? A lot of our recommendations, we need to get ID involved, make sure the patients can be treated optimally, especially from a selection and duration perspective. One of the biggest questions I get is, how do I know what to do with this? I'm not trained like Brad is, and it's on a weekend that we're doing now, or it's like I'm on vacation or I take a day off. This is something that I created to kind of help my colleagues to figure out, what do we do with this information? So at the very top, it tells me about the organism that's identified. It looks to see if there's any resistant determinants. A little bit of comments about what this means, and basically what is the optimal empiric regimen, or basically what would Brad do if he had this answer with the limited information. So in this example, if Enterococcus faecalis was detected and the VAN-A and or the VAN-B was detected as well, then that means that this is known as VRE, one of the VRE organisms, and likely comes from a GI, a gastrointestinal, or a GU, gastrourinary source. And at our hospital, it'd be very uncommon, but yet we do see it. And if they're symptomatic, then what would Brad do? Well, Brad would put them on daptomycin, because remember, This is VRE, vanc resistant, so don't put them on vanc, it's not going to work. And for me, the drug of choice is daptomycin, and daptomycin for enterococcus needs to be at least 8 to 10 mg per kg once a day if they have normal renal function. And this is off-label dosing that I mentioned I would be talking about. Most experts agree you need to use higher dose. We're using the idea of the optimal antibiotic, the optimal dose, because we need to use higher dose, and we're doing this all on the front end. We'd also need to say, place them in isolation. They have a VRE infection going on. We may need to recheck blood cultures if we're not sure if it's real or not, or to see if they've sterilized the blood once we've started the antibiotics. Consult ID in our hospital is required if you're on Dapto, and we just recently added it. If you have enterococcal bacteremia, it's an automatic ID consult. And if you're not sure if it's real or not, would it be helpful to check a procalcitonin? So in addition to determining if they're on the best antibiotic or not, then we're going to have the recommendation. Are they being treated optimally? And we're going to contact the physician, but only in our hospital if necessary. If there's a recommendation, we're going to go ahead and contact them and say, hey, this is what we think you should do. We can put in our little stewardship agenda in addition to letting them know this is what the organism turned out to be using this technology. We also have an opportunity to educate physicians. Not every physician knows that a Staph aureus bacteremia needs to be treated. They say, it's just 1 out of 2, he looks fine, it's a contaminant. Not with Staph aureus, we pretty much need to always be treating a Staph aureus, and they may or may not be aware of it. They may not know what is the drug of choice for methicillin susceptible Staph aureus. It's the beta-lactam, not vancomycin, assuming they can have that beta-lactam. Continuing on with getting this technology approved, we need to start preparing for things like IT. How's this going to be reported? How's it going to show up in the computer system? And then accounting for billing purposes. How are they going to do that? Because there's different ways to charge for that. And then you got to actually perform the pilot itself, actually start doing your patients. Once you've gotten the patients, you need to go ahead and do some more research. Round number 2 research, you need to collect all that data that you just did in that data collection form, and then you have to analyze it. And then you got round 2 of presentations where you looked at all that data, you analyzed it, and how did it turn out? What were your outcomes? Did you see a decrease in length of stay and some other things? So that's exactly what we did. Since we did a pilot, we had to do that final research project. So the purpose of our pilot was to determine the potential clinical and financial impact of implementing this technology of positive blood cultures with gram-positive organisms in conjunction with our stewardship program at our hospital. The primary objective was to determine if this technology had an impact on the hospital length of stay, with secondary impact of ICU length of stay, time to that optimal antimicrobial regimen, which again, as a stewardship pharmacist, that's what I tend to focus the most on. But then we also looked at hospital cost. From a methodology, this was IRB approved retrospective chart review. In the Rapid Diagnostic group, we looked basically at a 3-month time period once it was up and running for a couple of months. And historically, we looked at the same time period, but 1 year earlier when we didn't have the technology. Our historical control were basically any patients who were admitted that had a positive blood culture for a gram-positive organism. And in the intervention group, it was the exact kind of patients, but those that actually had the RDT performed. Exclusion criteria is listed there, with the most common being patients who basically had positive blood cultures in the ED department, but they were not admitted. The numbers that we had, we actually looked at 188 blood cultures, and out of those, 99 were in our historical control and 89 in our RDT group. Both sides had very similar exclusion criteria, but again, ED patients who weren't admitted being the most common. And that left a nice, even, clean 73 patients in each arm, which made for the study a lot easier to perform. Baseline characteristics were very similar between the 2 groups. There was a statistical difference between recommendations accepted. All the recommendations we made in the RDT arm were accepted, but we still had a pretty decent recommendation of 83% in the historical control arm. So what kind of recommendations were we making? 81% of the time, some kind of change in their antibiotics. Start, stop, or modify. Almost half the time, 42% of the time, we actually recommended an ID consult. And then 15%, some kind of additional lab test, a repeat blood culture, maybe checking an echocardiogram, whatever it was. The organisms that we isolated are listed here. This graph kind of shows that we see the majority were coagulase negative staph, but we also did see some Staph aureus and enterococcal species as well. And between the 2 groups, there's no statistical difference to suggest any kind of differences in our outcomes. This broke down the organisms a little bit deeper. We did see a statistical difference. We had slightly more methicillin susceptible Staph aureus and Staph epi in our RDT arm. The number of patients that actually had a pathogen versus a contaminant were similar on both sides, which is important to be realizing, make sure that wasn't going to impact our numbers. And the final thing was, how specific was it? Did the RDT turn out how it should have based on the final culture result? For the outcomes, again, we primarily looked at the length of stay. The overall hospital length of stay went down by 1.3 days, but was not shown to be statistically significant. When you look at the ICU length of stay, it went down by 3.5 days, which was pretty impressive due to some variation that we think that's why it didn't show a statistical significance, but we still were very happy to see a 3.5 day reduction in our ICU length of stay. The secondary outcomes was time to that optimal antimicrobial regimen. For me, this is one of the biggest things as antibiotic stewardship. From the time that it turned positive to the time that we got the results in the historical control arm, it took almost 2 days at 38 hours. But you can see after we implemented this technology, that got cut down by over 55% or 21 hours down to 17 hours. And that was shown to be statistically significant with a p-value of 0.01. The status of the blood cultures when we got the results of the RDT, you can see about 2/3 of the time, all we knew was it was a gram stain. All we knew it was gram-positive coccidiosis clusters. The other third of the time, we knew it was maybe a staph species, but we didn't know what species it was. Looking at the financial impact, when you look at the cost of what we spent on antibiotics for the 3-month period, and you added them all up together, before and after, we saw an $11,000 reduction in our antibiotic expenditure for the 3 months. When you look at the hospital costs before and afterward, it actually decreased by $159,000, again, over the 3 months. You take that 3-month period, and you actually extrapolate it out to a full year, and an estimated savings is about over $600,000. Now, despite me doing my best efforts, they still said I couldn't have all the tests for free, and I tried to do that. So I did have to incorporate the cost of the test, but you can see based on here, the cost in relationship to what we actually saw in the savings really wasn't even close. The net savings overall, we were estimating to be over $600,000 a year. Some barriers and limitations associated with our pilot that we kind of learned from. First is, do I think that this RDT was the only thing that made a difference in length of stay? I don't think so. Anyone that does think so, I think they're missing likely some other things. However, I do think it was a factor involved in it. One limitation I spoke on is that at the time we were only doing the RDT Monday through Friday, and again, very limited time period. If we can expand it out to multiple days, maybe later in the day, to where that time from it turns positive to time we actually run it, if we can shorten that time, perhaps we would get a bigger impact on our numbers. And we did realize a little bit into it, we had some issues initially reporting our results. They would say Staph aureus, but they didn't say anything about the MEC-A if the MEC-A wasn't detected. If it was detected, they would put it in. But if it wasn't detected, they would not say anything about it. And I said, no, we need to say that the MEC-A was not detected, because otherwise they don't know that it was even evaluated. So those are some lessons learned. Understandably, there was some initial reluctance by physicians. We get this brand new technology and they're used to the culture process, and all of a sudden you're telling them as soon as it's positive, oh, hey, this is MSSA, we can go ahead and just put them on ANSEF. Or, oh, it's just a coagulase negative staph, it could probably stop it, it's probably contaminant. They're like, what, are you sure? I'm used to doing vancomycin for a couple of days. But once they started realizing whatever Brad said it was is what it actually turned out to be, then they gained more confidence and got used to it very quickly. One thing we knew, if we were going to get this past administration for the cost, as much as we knew it was going to take additional resources to do it, both in the micro end and in the pharmacy end, we couldn't ask them for additional FTEs to do it. And it was hard because we knew we're going to have to incorporate it to our current responsibilities, and we're all busy, of course. But if you can incorporate it and that decrease your cost, so the estimation for your program administration was more likely to get it approved. And then related to that is the time to prepare for all of it, the policy procedures, the algorithms, the time to actually perform it on the patients, do all the data collection, analyzing the data, showing the outcomes and all the presentations. There's a lot of time involved in it, and it's still ongoing a lot of time, but it's time that I think that was well worth it. A little follow-up analysis that we did looking at data from 2015, 2016. Combined, we looked at almost 1,000 patients during that time period, and 92% of the time it was an exact match of what we expected it to be. When you look at 2016, it was the exact same thing. We actually dug a little bit deeper, where again, 92% an exact match. The 8% was a discrepancy. That 8% was 40 patients, and we actually dove deeper into those 40 patients. Said, how often was the discrepancy identified really clinically relevant? Was it significant? And we found out that only 7% of the time, or only 3 patients out of almost 500 patients, only 3 had a clinically significant discrepancy that ended up being an issue. Again, looking at the combined of almost 1,000 patients, about 2/3 of the patients it deemed to be just a contaminant. We seem to have a blood culture contamination rate issue going on here, but about 27% of the time it was deemed to be a pathogen, and then 12% we just don't know what it was. It could be real, it could be a contaminant. We weren't sure at the time. So we took this data, how often we make a recommendation. Well, that recommendation is only I say, is 32% of the time did we make a recommendation out of the 1,000 patients. And some people may say, wow, just a third, you're only using it really clinically relevant for a third of your patients. No, it's actually being used much more often than that. But our process actually changed quite a bit to where physicians are now currently waiting for the RDT result before they do anything. They're knowing we're going to look at it and call them if we need to start something up, if they're not significant. So if they didn't start something and they're waiting for us and we say, yep, it just turned out to be a staph epi, probably just a contaminant, then they don't do anything. Therefore, there's really not a recommendation that is needed to be made. Our acceptance rate, 78% of the time was accepted, but 13% they made some kind of modification to what we recommended, which means 91% of the time they're accepting our recommendations, which means they have a lot of confidence in the results and what we're recommending based on those results. Similar to the pilot, 77% of the time we recommended some kind of change in their antibiotic therapy. A third of the time we recommended to get an ID consult, and 21% of the time some kind of additional lab or test. To go over a patient case, and this is an actual patient case from several years ago that came in. We had a 37-year-old guy who came in. He had a chief complaint of a fever and shortness of breath for the last 4 days. He said at home he had a temperature of 102, and that was confirmed in our ED department. He said he's been taking Tylenol and Motrin, and it really just hasn't really broke. He's got a significant past medical history for diabetes and hypertension. He's got a noticeable social history that he says he takes, he does drink every once in a while, and he does admit to using IV drugs. And he's known to have a penicillin allergy as well. When you look at the labs, the significant labs, he did have an elevated white count, and he did have bandemia, and his renal function was deemed to be normal at the time. This patient was admitted into the hospital for community-acquired pneumonia, and he was sent to one of our floors and not to the unit. And they replaced him on levofloxacin IV empirically at that time. The following day, one of the blood cultures turns positive. The gram stain said gram-positive coccidine clusters, and we started the rapid diagnostic test. In that time, the micro notified the nurse notified the physician. Physician says, all right, go ahead and start Vancouver Pharmacy. Meanwhile, the RDT comes back a little bit later, and it detects a Staph aureus, but the MEC-A was not detected. The pharmacy then assesses, says, all right, we know this means it's MSSA, or methicillin susceptible Staph aureus. That Vanco that just got started in the initial Levaquin, we don't need either one of those. We need to put them on cefazolin. So we put them on the optimal drug and at the optimal dose of 2 grams IV every 8 hours. We recommend an ID consult because we know patients with a Staph aureus bacteremia have the best outcomes when an ID physician is on board. We also recommend to check an echocardiogram because I was concerned that this patient had risk factors for endocarditis. And I also recommend to check a CT of the chest because I was concerned that if he had right-sided endocarditis, that could actually be vegetation that has now showered off into his lungs, and he actually could have a septic pulmonary embolism. How did it turn out? Well, the physician agreed with all the recommendations. He agreed to switch it over to cefazolin. In this case, the patient did not receive any doses of vancomycin because we were intentionally maybe delaying the antibiotic from getting started because we knew the RDT was cooking. ID did get consulted. They weren't able to see till much later in the day or maybe in the next morning. It's been a while for me to remember. They did an echo, and sure enough, it did show tricuspid valve, which is on the right side, endocarditis. And when they got the CT results, it did show multiple pulmonary emboli. They decided to transfer the patient to the ICU just for closer monitoring because of the PE. 3 days later, the patient was transferred back to the floor, and then 3 days after that, he was discharged on a total of 6 weeks of IV cefazolin. So what were the potential benefits of the technology in this case? Well, the first thing is the faster time to the optimal antimicrobial. For example, evidence does show that a beta-lactam does have better outcomes than vancomycin. In this case, the cefazolin was better than vanc. We were able to avoid unnecessary antibiotics. For example, vancomycin, there was no need for vanco in this case. We just didn't know it on the very front end. This patient had several risk factors for acute kidney injury. The patient had diabetes, hypertension. He said he was taking ibuprofen, which is an NSAID, before he came in. And one thing that a lot of people don't think about, he actually got IV contrast for that CT. All those in combination with vanc are a recipe for disaster and causing AKI. The patient was also on Levaquin for that pneumonia that turned out not to be pneumonia. And Levaquin has a lot of side effects, including the risk of prolonging the QTC interval and the increased risk of developing C. diff. The patient also has an increased likelihood of survival now. Again, the faster time to the ID consult means they have a higher likelihood of surviving. That endocarditis and septic PE diagnosis, I don't know if it would have happened if we didn't know the test earlier on and we made that recommendation. And again, that faster time to that optimal antimicrobial therapy increases his likelihood that he's going to survive. I mentioned earlier how there's antibiotic stewardship guidelines from 2007. There's actually an updated version as well. Instead of having to justify it and maybe design it, there's actually newer guidelines that talk about what are some specific things we can look at. And within these new guidelines from 2016, there's a very specific question in there. And it asked, should antibiotic stewardship programs advocate for rapid diagnostic testing of blood specimens to optimize antimicrobial therapy and improve clinical outcomes? In their recommendation, we do suggest RDT testing in addition to the conventional culture and routine reporting of blood specimens, as long as it's in combination with an active stewardship program to be able to interpret it. They also talked about how the availability of this technology is expected to increase, which it already has in the 2 years it's been out. The stewardship programs must develop processes and interventions to assist patients in interpreting and responding appropriately to these results. So in summary, this technology is an excellent opportunity for antibiotic stewardship programs, and is actually formally recommended in the antibiotic stewardship program guidelines. We reviewed key metrics that can be looked at if you're going to consider looking at this technology, such as improved clinical outcomes, the decreased time to that optimal antimicrobial therapy. Again, stewardship programs, that's what we need to be focusing on. The decrease in length of stay, both in the hospital and ICU length of stay. And the potential to actually increase the likelihood of survival. And there's also improved financial outcomes as well, because we know it's not a cheap thing for our micro department to be doing, but for the net benefit of your health system, you should see a financial benefit. We reviewed the various workflow responsibilities of both micro and pharmacy. And I hope after the last 50 minutes of me speaking that you've hopefully been able to determine that this technology really is feasible, and it's not just in large academic medical centers, but also in a non-teaching community hospital such as ourselves. And with that, I'll be happy to take any questions that the audience may have.
Fantastic. Well, thank you so much for that, Dr. Green. Lots of really insightful information here for everybody today, so thanks for that again. At this point, I would like to invite our audience to continue sending in their questions and their comments right now using that questions window. This, of course, is the Q&A portion of the webinar, and we've got a couple of questions here already, so let's get started. Our first question, have you seen this testing help manage patients with contaminated blood cultures and de-escalating treatment on them quicker?
That's a great question. Actually, this technology has had a very significant change. Most of our blood cultures here do tend to be contaminants. We have a blood culture contamination issue at our hospital that we're tending to focus on now. So we tend to be busier than I'd like to be with this technology. But with us being aware of that, originally, like I said, that knee-jerk reactions put everyone on vanc, and our physicians now realize how important this technology is, and they're reliant on it. So a lot of times when they get reported a positive blood culture, they're sending me a text. They say, hey, are they doing an RDT on so-and-so? And I'll call micro, and they'll say, yep, it should be up within this much time. I'll text them back and they're like, great, let me know how it turns out. I'm not starting anything until you tell me what it is. It comes back and it's, nothing is detected. They have no symptoms. I'm guessing it's micrococcus, or there's a staph epidermidis, or it's just staph species detected, and it turns out to be like a staph hominis a couple of days later. With us realizing we have a relatively high contamination rate issue going on here, they've taken that information and they've totally revamped their process. They're not starting antibiotics unless they're truly symptomatic, and they're waiting on this technology to go ahead and do it. So the contaminated blood cultures, a lot of times this is resulting in patients not getting any antibiotics, which is really, really good, and we're not necessarily exposing patients to unnecessary antibiotics. Good question.
Great, thank you for that. Moving to another question here. Does this testing replace conventional ID and susceptibility testing?
Another good question, and it's really important to say that this will not replace that technology or that current conventional process. This information gives us a lot of the key information faster, so it does help identify it when it is able to be identified, such as a Staph aureus, Staph epi, etc. And it does give us some of the resistant determinants, but one thing it does not do is give us any susceptibilities with MICs, and it doesn't list any of the antibiotics. So in addition to us knowing what it probably should be susceptible to, if it's something like group A strep and it's penicillin susceptible, if it's like a Staph aureus, we need to know what is the MIC to vancomycin, is it susceptible to these multiple other antibiotics? So it is very important to note that using this technology is in addition to the current microbiological process, not any kind of replacement at this time.
Excellent. Okay, thank you for that as well. Another question. So this audience member writes, when a patient is admitted from the emergency department and its blood culture came out positive with gram-positive cocci in 1 out of 2 bottles in the sample taken in the emergency department, do we still need to run RDT or wait for the second test to come out positive? So what are your thoughts on that?
You'll have to discuss that internally. What we've decided to do for multiple reasons is that every positive blood culture, including every positive blood culture collected in the ED, whether they're admitted or not, in our hospital, every positive blood culture gets tested with only a few exceptions. The exceptions basically being if it's the second bottle and the first bottle we know is already a Staph aureus, or if they've had previous positive blood cultures and it's a new positive one and they just haven't sterilized their blood cultures yet. Those are the only times that we're really not testing it because there's really no benefit in it. But if they are in the ED and it's 1 out of the 2, we're absolutely running it. And we're not delaying it because it could be a patient has a Staph aureus bacteremia and they were discharged from the ED, and then we actually will call them, have them come back in to be actually admitted so that we can work them up properly and put them on the optimal antibiotics. If the patient's already been admitted, and if it's 1 out of 2, probably depends on the clinical picture. Why were they admitted? Were they admitted because they had some kind of hip fracture and the blood culture is not suggesting anything that probably is relevant to their clinical case? Then hopefully it'll just be a contaminant, but we still want to know is it a contaminant or not? Or is there something else going on? Maybe that's why they fell, or were they here for pneumonia and that's why they're bacteremic now, because it's going to be a strep pneumobacteremia, and we never get an isolate that grows out of the respiratory tract, and we can confirm, nope, they had strep pneumobacteremia, and we can put them on the optimal antibiotic on the front end. So again, in our hospital, we test every single positive blood culture, plus it makes it a lot easier for our micro of trying to figure out, do we need to test it or not?
Mm-hmm. Okay, lots to consider there. Thank you for that. Another question here. What were some of the biggest implementation challenges and how did you address those?
It's been a few years since we implemented it. For me, one of the biggest things was just the time of trying to bring everyone together. It was just a combination of trying to incorporate into our current responsibilities. I wasn't very knowledgeable at the time, so I was kind of learning about what this technology would do and how to interpret it. I've had multiple versions of that interpretation guide that I showed you after learning what may or may not be included. Originally, we had some of our physicians a little reluctant, like I was saying, of really believing, is this really what it would turn out to be, when they were so used to keeping everyone on vanc for at least 2 or 3 days. A lot of times that was unnecessary. So those were some of the barriers. Personally, when I was meeting with our CFO, I was actually thrown under the bus a little bit. So a little personal experience where my CFO I made my pitch, and my CFO went to the lab director, who I thought had my back, and he said, well, honestly, Mr. CFO, if you're going to give me money for a project, I want to buy a new BMP machine. And I had to go in reflex mode and say, oh, well, that BMP machine isn't going to have any impact on patient care, but this technology will, and I'll actually save you money by doing this. So that was an unexpected barrier for sure. But most of the other ones were relatively expected. Like I described before, how we were reporting it, some of the timing issues, things like that. But those are all things that we worked through, and things are on just automatic pilot right now.
Mm-hmm. Okay, thanks for that. As a follow-up to that question then, what would be your recommendations for facilities implementing RDT with a lack of infectious disease doctors on staff?
That's a good question. For me, hopefully, every hospital probably should have some kind of ID, someone who's kind of in charge. If it's not an ID trained physician, it's someone who's willing to take the lead in ID related issues. It could be if you have an ICU physician, most of our ICU physicians are going to have to be well versed in ID concepts. It could be a hospitalist that is willing to accept that challenge. So there needs to be definitely a physician champion associated at your hospital to kind of help develop some of the algorithms and guides of what you guys tend to agree with. With the mandatory aspect from CMS and Joint Commission that all hospitals have to have antibiotic stewardship, at least a lot of the antibiotic stewardship programs are at least addressing who's going to be taking the lead. So whoever's taking the lead with stewardship from a physician perspective is likely, hopefully, going to be also to incorporate this aspect as well. I would think as long as they're involved, there could be like possibly like a telecommunication type thing. It could be just a one-time consult. If you don't know of someone, you could maybe reach out to facilities that do have someone with some additional expertise. There's plenty of resources out there now. And I know there's people at Luminex that are also willing to kind of help with some of that guidance as well.
Okay, excellent. So it sounded like we needed a physician taking the lead on that. To follow up with that, how long did it take for physicians to become comfortable with the rapid results?
Yeah, we actually had physicians on two ends of the spectrum. We had some that were buying straight into it on the front end, and they put all into it. And actually, we have two ID physicians. One of our ID physicians was very reluctant, where the other one kind of bought in real quick. And I think when they kept seeing time after time after time after time, whatever the technology said it was, and I would interpret it for them and say, this is what it's going to turn out to be. And pretty much every single time it turned out to be exactly what we said it was going to be. They just needed their own personal experience to see it for themselves with their own eyes and their own patients before they got comfortable with it. And it's understandable. I would be reluctant at first as well if you weren't familiar with it, but there's been enough going on to where we have enough confidence in this technology, and especially with the Luminex product with Verogen system, to where we know what it should and shouldn't do, and enough other places have had great outcomes and the accuracy of the test. But it's going to depend on the individual physicians, in my opinion.
Okay, excellent. Thank you for that. Maybe time for one or two more questions here. Next question. How difficult was it to implement the RDT process into the electronic medical record?
It's going to depend on your system. Our system was not very user-friendly. For the micro, they actually they have a template, but they put it in the SunQuest, and they have to manually put it in, and it crosses over in the Paragon. I'm going to kind of defer that to you, depending on your various technologies, computer systems at your institution, and if you have any questions, probably reach out to Luminex on that, because I only have experience with my one hospital with our current system, but it is a manual process right now for us with our current system here.
All right, excellent. Thank you for that. Looks like we have reached the end of the question and answer portion of this webinar, but if you do have any further questions for Brad Crane, you can address those to the email address showing on your screen right now. That's crane2001@gmail.com, or you can reach out to him also on Twitter at ASP_PharmD. And if we weren't able to attend to your questions today, the team at Luminex may try to follow up with you after the webinar. And thank you everyone for participating in today's conference. You'll be receiving a follow-up email from X-Talks with access to the recorded archive for this event. and a survey window will be popping up on your screen shortly. Your participation is appreciated as it'll help us improve our further webinars. Now, I'm just about to send you a link in your chat box. You can share this webinar with your colleagues using that first link, or you can do so directly on LinkedIn using that second link I sent you. So I encourage you to do that if you found this helpful today. So we hope that you all found this webinar informative, and have a great day, everyone.